Thank you all for attending today. I'm Nancy Baxter. I'm head of the School of Population and Global Health at University of Melbourne. And I'd like to welcome all of you and our panelists to this webinar today. First, I'd like to acknowledge that I am on the lands of the Wurundjeri people. This is lands that have not been ceded ever. This is Aboriginal land now and always. It has the Aboriginal people of the Wurundjeri people have been custodians of this land for thousands of years, and I pay respects to their elders past, present, and emerging. Well, it has been 326 days since the first patient with COVID-19 was diagnosed in Australia. We, of course, had no name at the time for this novel virus that's now affected every aspect of society worldwide, with almost 70 million infections and 1.6 million people dead of the disease. Hope for rapid development and distribution of a vaccine seemed a dream. It seemed really wishful thinking. But here we are now with multiple candidates and the first dose actually given off trial 2 days ago in the UK. Many questions remain, however. We have just had two occurrences of allergic reactions that have concerned everybody. We also have the issues related to needing to keep the vaccine in -70 freezers. So there are a lot of questions and details that remain in terms of moving forward with vaccinating Australia. So we're very pleased to present this webinar. Are we there yet? The road ahead to vaccinating Australia against COVID-19. The school is presenting this with our partners, the Global Health Alliance Australia. So the Global Health Alliance is an innovative and trusted alliance of member organizations based in Australia, which drives change through specialist advice and expertise, influence, advocacy, connections and networking, and collaboration and investment. The alliance aims to advance health equity and health security through sustainable development in our region. This is also given in conjunction with the Melbourne Population and Global Health Student Society. The Student Society is a non-for-profit organization whose aim is to provide a platform that enables networking and growth amongst students at the Melbourne School of Population and Global Health. I'm joined by our fantastic panel members, Professor Chang, Ms. Sonia Ellis, Dr. Ross McDowell, Professor Jody McMahon, and Dr. Magda Santos. But first, the housekeeping. So we will be taking questions at the end. This will be a moderated panel for the first half, and then the second half we'll be taking questions. So please post your questions in the Q&A box. We also have our hashtag COVID-19 vaccine. So please, if you're on Twitter, tweet using the hashtag and we'll be able to find your tweets. We encourage viewers to use the gallery view. That tends to be the best way to view this. And we'll be also posting a recording on YouTube, and we'll be forwarding registrants the link to the YouTube video so that you can share and watch at a later date. We also are interested in your suggestions for future seminars. So we will be posting the email for the Student Society and are happy to take ideas for future seminars about things you'd like to hear about. So first, let's have our panel tell us for just a brief couple of minutes about what they think are the key things in terms of planning for vaccinating Australia to COVID-19. So first we have Professor Chang. Chang is the Director of the Infection Prevention and Healthcare Epidemiology Unit at Alfred Health and is Professor of Infectious Disease Epidemiology at Monash University. He has been closely involved in the COVID-19 response, including as a member of the Australian Health Protection Principal Committee and as Acting Victorian Deputy Chief Health Officer. Alan.
Thanks very much, Nancy, and thanks for inviting me an opportunity to talk today. So, I mean, I think this is going to be a very complicated exercise for many reasons. We have, it's a new vaccine. It is going to be, there's going to be limited supply. It's going to be rolled out possibly to the whole population. And this is going to make it really very much a logistical issue as well as a health issue. And if we've learned anything in Victoria, it's that we need to make sure that both of these are covered off. That we have very robust processes to make sure that all the logistics are managed, but also all the things around it, who's going to get it, and any side effects that happen, that there's a sort of a health wrap around that logistical exercise. The key questions at the moment are, what vaccine are we going to get, who we're going to give it to, and how are we going to give it. There's obviously lots of experts around the table that can help us with those questions. And then as this gets rolled out, and obviously in the United Kingdom, this is becoming an issue already, how do we ensure that we have adequate monitoring of safety, and can we maintain confidence in the program? There's obviously been a lot of thinking about this at various levels of government. So it's just being sorted out at the moment, the roles of the Commonwealth Government and each of the jurisdictional governments. And then there are advisory committees that have been formed partly to choose which vaccine and which to help government decide what investments to make in terms of vaccines. And then ATAGI, which normally is the expert advisory committee about all vaccines, has formed some working groups, again, including some of the members of this committee, that are helping with those questions about who are we going to be vaccinating, how are we going to roll it out, what are the implementation issues, and then ensuring safety and monitoring and evaluation and uptake in the community. So I might stop there and pass over to.
Terrific. Thank you very much. So then we have Sonia Ellis. So Sonia is a nurse practitioner with a specialization in immunization. So after choosing to specialize in immunization in 2003, Sonia became an integral part of the Royal Children's Hospital Immunization Service, and in 2017 became Victoria's first nurse practitioner in the field of immunization. She has a particular interest in vaccine hesitancy, special risk groups, needle phobia, and immunization education. In addition to her role at the Royal Children's, Sonia is a current member of the Immunization Coalition and holds honorary positions at the University of Melbourne Nurse Immunizer Program and the Murdoch Children's Research Institute. Sonia, what do you think are the main issues?
Yeah, well, thanks very much for the invitation and being the panel. I mean, obviously esteemed company. So I think, obviously what Alan has already talked about, and I think we're very lucky in Australia that we're going to learn a little from the UK experience, and given that our epi is quite low at the moment, we've got some things that we can really get in place, I guess. I think the critical things that I see is really improved communication. I think we really need to get that right, not only to the public in terms of talking about vaccine safety and confidence, but also to providers, and really allowing them to get their ducks in a row before the vaccine's actually here. One of the other things that I think is really important is rapid delivery of it, training and education for providers. I think what we've seen previously with pandemic vaccines in 2009 with PanVax was, a lot of error that occurred with delivery of the vaccination. And so we need to make sure that we've got these sorts of things ready to go, and that we've got a workforce, ready to deliver the product as well. So I think, getting some training and education is really important.
Terrific. Thank you very much. So next we have Dr. Ross McDowell. Ross is an ethicist in the School of Population and Global Health at University of Melbourne. Her research and teaching focus is on the ethical challenges faced by health professionals. Her background is in philosophy and qualitative research, and she brings these ideas and approaches to interdisciplinary analysis of issues in patient care. Roz has been involved in providing clinical ethics support to hospitals since 2008 and co-founded the Australasian Clinical Ethics Network. In 2018, she was selected as one of ABC's top 5 researchers in the humanities and social science. Roz, what do you think are the critical issues?
So from an ethical perspective, the big question is really about prioritisation of vaccine in Australia. So given that supply will be limited initially, who's going to be first in the queue, and not just first, who's going to be second and third and so on down the list. And we're seeing in different countries slightly different approaches to prioritisation. So in the US, for example, healthcare workers were there at the very top of the list, whereas in the UK, aged care residents and their carers were the number one in terms of their ranking. So in prioritisation lists, we're seeing high-risk medical conditions, older age groups, essential workers, all up there near the top, but ordered in different ways in different places. But these kind of context-specific rankings are certainly ethically justifiable because there's not going to be a one-size-fits-all kind of ranking approach that's going to be appropriate across the different social structures in different countries and the different COVID situations in different countries. So the question now for us in Australia is, what's the best ranking for our context? So given our social structures and our COVID situation, what kind of vaccine queue do we want to create in Australia? And so far in Australia, a set of possible priority groups has been made public, but we haven't seen any ranking of those groups yet in our context. And I think it's really important that the process of arriving at a ranked list is in itself a fair process. So the WHO has highlighted the importance of what they call legitimacy in making these kinds of decisions, that these decisions need to be made through transparent processes with appropriate input by affected parties. So my hope for the road ahead for Australia and vaccination is that we can create a well-justified ranking that's specific for our context and one that's been reached through a fair process.
Thank you, Roz. That sounds very sensible. So next we have Professor Jody McMahon. So Jody is a public health physician and epidemiologist. She has extensive expertise in clinical vaccine trials, epidemiologic studies, and mathematical modeling of infectious disease gained in Oxford, London, and Melbourne. For the past 15 years, she's been building capacity in infectious diseases modeling in Australia to inform immunization and pandemic preparedness policy. How timely. She has led nationally distributed networks of modelers informing responses to the 2009 H1N1 influenza pandemic and the current COVID-19 pandemic, of course. Jody, what do you think are the key things?
So I guess I'm framing it as a modeler, and if modelers have a use, it's helping to make decisions in the face of uncertainty. So as you pointed out, Nancy, where we really wanted to be, but actually now we've got something that we have to work out what to do with. I would not have believed 11 months ago that we would have 95% efficacious vaccines. Here they are. How are we going to use them? So like everything else in the past year, we have to make decisions. We have to make them quickly. They have big consequences, and we're making them in the face of imperfect evidence. We do not have all of the information that we would want to make decisions, so we have to make best use of available evidence and make decisions in a risk-benefit framing. So that's tricky. And you know, some of the key uncertainties we have about the vaccines are whether they simply prevent disease or whether they also prevent infection, in which case they may be able to provide transmission benefits. They might be able to reduce the spread of infection and have wider benefits than just in those immunised. That would be great. That would be a real bonus at this point, but we're not sure. And that actually is important because knowing that changes the achievable objectives of a program. You know, what groups should we immunise to achieve benefits in other groups? And that actually feeds into all of the allocation and equity and prioritisation arguments. Who can we protect? You know, where are the additional gains of a program and how can we make best use of our resources? So all of that is being done in a scenario-based way. And as has already been pointed out, we're in a very different position in Australia from other parts of the world. So, you know, appropriately, our vaccine approvals process is taking longer and not going through an expedited pathway as it is in countries where there are, you know, many cases and deaths. I mean, it is a quick pathway, but not as quick, not an emergency use authorization. And so, you know, different countries are going to have different level thresholds to be able to roll out a vaccine. And we also will be having to find out whether countries that have had high levels of exposed populations actually, you know, see the same vaccine characteristics as countries like ours that have had really very few infections, and how vaccines last and how long they last and all the other things we won't know until we have time. And of course, that's very frustrating because we all want to know now. So I think we have the challenges of dealing with uncertainty, managing expectations, anticipating that we will need to keep public health and social measures in place for some time to reduce transmission, and keeping that a message alongside, but also, as with everything else we've had to do, remaining adaptable. So this is a big communication challenge of saying we don't know now, we're acting on our best knowledge, but if we find new things, we need to incorporate those into the messaging and the strategy and bring the public with us, you know, which is always us changing our minds, but is going to be essential for best use.
Absolutely. So then we have Dr. Magda Santos. So Magda is a practicing GP, a GP researcher, and a health advocate with regular publications in mainstream medical media and appearances on national radio. Magda has represented the Royal Australian College of General Practitioners in national health policy development and at Senate inquiries. She's a senior research fellow with the Department of General Practice at University of Melbourne, and her other appointments include the Royal Australian College of General Practitioners Expert Committee for Quality of Care, the Women's Health Victoria board member, and president of the Australian Federation of Medical Women. Magda.
Thank you, Nancy. Well, thank you for inviting me. I think this is a really exciting phase in the next phase of our COVID experience, and implementation of the COVID vaccination strategy requires close engagement with the GP community. We're frontline workers and we're central to this, as the waves of the COVID-19 have proven in Melbourne. GPs are ready to mobilise and protect their communities, their staff and themselves. So we're not just diagnosticians and clinicians, and we're also educators of the public, and as such we actually really need to be at the coalface of this public health initiative. And I've broken up my presentation or my talk into three parts. It's around what we've learned, you know, what we have and what we need. And what we've learned is that GPs are the first port of call for information when things go wrong. Yep, we need to engage GPs in the development of these education tools, and we need consistent messaging across the health system. And that means from, you know, researchers, policymakers to healthcare workers and the public in an integrated process of communication with data collection and feedback around this vaccine, because it's all very new. And we need really good community engagement with education tools and national health promotion. So we need a national effort. I think, you know, we've touched on this already, that it's a shared vision for a healthy Australia, and that we do have to be able to deal with the unknowns. And for this, I think misinformation needs to be countered whilst we're also dealing with valid vaccine fears. So, you know, these need to be acknowledged and listened to. So we have to have a port of call or a reference point for information for these questions. So what we do have, we've got really a pool of outstanding, you know, primary care practitioners, doctors, GPs, nurse practitioners who deliver, you know, an existing world-class immunisation program with protocols, recall systems. And, you know, we also now have an electronic health record, you know, and hopefully we'll have a central registry for the vaccine. I think that we need to have something a bit like the Australian Immunisation Register, but we need something very specific, which is a register, as a register specific for the COVID vaccine. And so we can track and trace who's received it, where, when, and also have recall systems for the second doses. One dose is not enough. So this is a key message we've got to get out to the public. What we do have also, we have, you know, respiratory clinics which can be repurposed to actually facilitate this delivery of the vaccine. And we've got hospital staff and departments that have activated to become vaccination centres, that can activate to become vaccination centres, which they're doing in the UK. So, you know, we've got primary healthcare networks that can be engaged in community education and also provide information in languages other than English for our linguistically and diverse communities. And we must make sure that whatever education and communication we deliver, it's in the language of the people, not in English that's translated directly into another language at a level that we expect health literacy is at or should be at, because it's not. So what we need is we need a consent process too. You know, GPs are going to be asked, you know, what do you think of this, doctor? And we've already been asked about this already. There aren't consultations now where the conversation doesn't revolve around the COVID vaccine. So GPs need to be prepared with you know, evidence and with more information around the vaccine type and what adverse events might be, and also be provided with reporting processes that are streamlined and easy to use. You know, reporting of adverse events is not mandatory, but it needs to be emphasised that this is an important part of this whole process and that we're building. And we need to have, a responsive team at the other end of the adverse events reporting that can relate to this and also respond to the concerns. So, just having a,
absolutely.
Yeah.
So I think let's get into it. Let's talk about some of these issues. So let's start, Alan. So, we have a number of major vaccine candidates, and Australia has secured a significant number of vaccines. Now, of the Pfizer vaccine, the 95% effective, or 90 to 95%, we have, 10 million doses?
So I don't know exactly off the top of my head, but just a note that they don't all come in on the same day. They will drip in over a period of time, so we won't get...
Right, so we don't even have 10 million at the beginning. We have 10 million at some point, and that's a 2-dose type of vaccine. So, we have the Pfizer vaccine. We likely will have the AstraZeneca vaccine. Can you talk a little bit about them and the differences in efficacy for the two vaccines? And how are we going to deal with the fact that we might be giving some people a vaccine that's 60% effective and some people a vaccine that's 90 to 95% effective?
Yeah, and then complicating that decision is, which one will arrive first, which one will be easier to distribute. So the Pfizer vaccine is the mRNA vaccine that's does look like it's probably pretty effective, 90 to 95% effective. The main drawback with that at the moment is that it needs to be stored at -70, which is a pretty big logistical issue. They're, certainly they're not the fridges that you find in general practice or in pharmacies in general. But having said that, the Ebola vaccine in West Africa was also a vaccine that had to be held at, I think, -60, and they managed to roll that out in obviously very challenging circumstances. So where there's a will, it's not impossible, but it is clearly a major issue. The AstraZeneca vaccine is a little bit more complicated. It's the one that the paper was published a couple of days ago, and it looks like there may be a few little issues with that, so that it's possible that with a half first dose that it may become more effective. The data's pretty scant at this stage, and they're almost certainly going to have to go back and do that study again to make sure that that actually is true.
Yeah.
And the other issue about the AstraZeneca vaccine, it looks at this stage possibly that it may not be effective against asymptomatic infection, and but it looks like it's more effective against severe disease. So we might have this situation where it's protective against severe disease, it's somewhat protective against infection, and not very little or no protection against transmission, which would obviously introduce another level of complexity.
Challenging. And so this is something that Jody brought up. So Jody talked about how, we think of vaccines as being a silver bullet, but that they may not be, and that, stopping severe disease is different than stopping transmission and infection. Jody, do you want to talk a little bit about that and how, what still needs to be in place as we vaccinate people, and when will you be sure we can stop washing our hands, if ever? So what should we expect from vaccines? What can we expect?
So the analogy that occurred to me the other day was HIV. We don't have an HIV vaccine, but we can stop people dying of HIV. We can give them effective therapies, but we still tell them to use condoms. So, there's potentially, if we end up with vaccines that reduce severe disease and death, clearly that will reduce much of the impact and burden and disruption associated with COVID. But even having large numbers of people with mild infections or moderate infections or presenting at once, particularly if younger adults, for example, aren't a priority group, could still be very devastating. And we know that there are real risks of long COVID, that some people who may even have a mild early infection may still develop long-term sequelae. So I think we are going to need to educate the public and really set realistic goals about the need for those ongoing personal preventive behaviours that every single person can do every time they leave the house or interact with someone else to reduce their risk of acquiring COVID and other respiratory infections. But, it's likely that there will still need to be other risk mitigation measures in place in shops and workplaces and other parts of society while we're rolling these vaccines out and learning more. And I think one of the concerns might be that people might get a bit overexcited and suddenly think game over, you know, a bit like coming out of lockdown and everybody goes a little bit crazy. But, you know, this virus is very much still around. It's very much still with us. We are going to be needing at some point to open up more to the wider world. And we're very aware of the risks of importation into our very naive population. So, you know, all of these things will need to be part of an ongoing social discussion.
So Sonia, you know, we've heard from Jody and Alan a lot of things we don't know about this vaccine. And, you know, I think to some people it kind of seems like, and I think when we talked, you talked about this, it might seem like the vaccine was kind of whipped up in the kitchen. It's been tremendously rapid in terms of its development. So, you know, how were they able to develop a vaccine so quickly? And you know, are you confident? What would you need to know to make you confident in the vaccines that we have?
Yeah, it's like my dad was just saying the other day, I don't want to be the first person to get the vaccine. It's like, Dad, you're so not going to be the first.
No, that was the 90-year-old grandmother in the UK.
That's it, exactly. You know, so I guess, you know, we really understand what happens in clinical trials. And I guess, you know, and I've been fortunate to be involved in, you know, the Brace trial, for example. And what normally happens is obviously, you know, applying for ethics can take a very long time, you know, to get all that, you know, your ducks in a row, etc. And then after that, you try and get funding, and that can take forever. You might not ever, you know, quite get enough money to run the study. And then you obviously need participants in your study, and recruitment can take forever. And Jody certainly knows, you know, that through Virgo. And sometimes you use incentives to get people to recruit into studies. And so that's, I guess, you know, the processes that have been expedited, if you like, in this setting is that, you know, people have been throwing money, you know, at conducting the trials. People are absolutely willing to participate in the studies. And so they're parts, you know, of the process that have been, you know, much more efficient. But also, look, the technology has been there. It's not like it's, you know, new, might be new in some ways, but, you know, and I guess with the clinical trials, you know, I'm really reassured by the rigorous processes that are involved. But as Jody said, we're still going to need, you know, this sort of post-marketing surveillance, and already what we're seeing in the UK is, you know, they're reporting allergic reactions. Now, we'd really expect to see allergic reactions, you know, following vaccination, whilst rare, and this will be really something for, you know, people to really address and talk about. What'll be interesting will be what is the background rate, what are the numbers of people being immunised, is there an early flag? And we've certainly seen this in the past with HPV vaccine when it was introduced in 2007. Myself and my colleagues wrote a paper on HPV and hypersensitivity reactions. It appeared that girls were having these allergic type reactions to vaccination, but in actual fact, when we then went on and did, you know, skin prick testing, turns out it wasn't actually, you know, anaphylactic in nature, and it was no more significant than the expected background rate anyway. So, yeah, I'm you know, reassured, and my job obviously as the nurse immuniser is to reassure the public with that sort of information.
Still, I'm sure we'd like to have a lot more safety information for a lot longer if you know, it was a perfect world and we weren't in a pandemic emergency. So Ross, how do we balance that? How do we balance kind of wanting to have the usual amount of information that we have on safety and efficacy, you know, with the need to actually kind of roll this out? And how might that be different in Australia than in other settings?
So the risk-benefit analysis is going to be different in different settings. So we've seen, you know, like the contrast, for example, between the situation in the UK and the situation here is enormous. So thinking about when the question is what's the benefit that we could do in our country with a vaccine that we know X amount of information about, the answer to that's going to be different in different places. So the benefit available from a vaccine is going to be context specific.
And I think that one of the challenges is how we interpret information and how much information is kind of coming at us all the time. And Magda, I know that when we talked, you talked about learning things from press release versus learning them from peer review, and how this is a very kind of different setting than usual, a different place for GPs to be than they're usually in. So, you know, how do we need to change the communication? How do we need to make sure that the healthcare providers that are going to be involved with talking to patients about vaccine related issues kind of know what they should be telling their patients about this?
Well, firstly, it requires direct involvement in the development of the information packages and the strategy that you're going to reach the public with. So that's key in terms of developing education communication strategies for the healthcare providers. But when you actually have situations where the media is taking situations that occur overseas and making big announcements that your patients read and access, then they come to the primary care practitioner, they come to the GP with that, and there isn't always evidence behind that question. There isn't information, there isn't a port of call, there isn't one reference point. So sometimes it is the patient who comes to the GP, and the GP hasn't in fact, the wider medical community hasn't at this stage reached a point where that information has infiltrated across all sectors, nor is it being researched locally. So we don't have answers for some of these questions, and it can be very disruptive to practice. It can also create heightened anxiety, which you don't want. And so we need to be able to, I mean, one of the things that I did initially when there were all these coronavirus myths and fallacies circulating, I wrote an article around that just to address the myths and the conspiracy theories that were being disseminated, so that our own community, our GPs, could have something to deliver to their patients when they were being asked crazy questions about 5G. And this is not dissimilar. This is going to be really interesting, because there's a lot of there's a you know, a very high level of concern in the community around vaccination that is as yet untested, and how we engage GPs in that is from the beginning with development of information around, you know, giving patients confidence. For adverse, what is an adverse reaction? I think what you touched on, Sonia, is really important, because there's a lot of misinformation around what you know, fainting, for instance, some people consider is an adverse reaction, which it's not. A local reaction, how big, how wide, how extensive, how long it lasts. So we need to have these really clearly stated and bring GPs up to a level of confidence so that they feel that they've got enough material to inform their patients with.
So in terms of approval, so Alan, we've seen emergency approval for the vaccine happening in the UK, Canada. It's gone in front of the FDA yesterday, and you know, probably will be approved this week. So obviously they've decided that this is warrants emergency authorization. What's the process for approval in Australia, and when's your best guess that this might be approved here?
Yeah, it's a good question. Basically, I think all the major regulators in the world are getting basically the same amount of the same information. You know, and the way that it's being done is what's called a rolling submission. So as data comes in, it's submitted. That's very different to a usual drug or vaccine, where it's all packaged up at once and then it's all submitted and then sort of hyped out, and often takes sort of 9 months to approve it. But clearly we're in a different situation at the moment. There's sort of three key parts to the question. There's the does it work, efficacy. There's is it safe, which actually takes a little bit longer, and probably a little bit it takes longer, and needs to be more people in that to make it more confident that it's a safe vaccine. And the third part is actually the manufacturing quality. So, you know, you make sure that there is no variation between batches of the vaccine. And as an example, the AstraZeneca vaccine, the reason why about 2,000 people in the studies got a half dose was actually a manufacturing quality issue. They thought that they were based on one assay, they thought they were giving a certain amount of dose to someone, but it turned out that there was interference with one of the substances in the vaccine, and they actually gave a half dose instead of a full dose, and obviously that's you know, perhaps fortuitous that we now know that maybe that's more effective, but that just really highlights some of the risks that are in this process. For each of these, actually, efficacy is actually, because this disease unfortunately is you know, relatively common, unfortunately, in many countries where they're doing the studies. that actually is the first signal. Does it work is actually the easiest bar to cross, and then it's safety. You know, can you give it to enough people to know that nothing bad happens in 30, 40,000 people? And then the quality issues then become also important, because we're making this in, you know, huge quantities. There are manufacturing sites being stood up all over the world, and we need to make sure that there is sufficient quality, that, you know, that people are getting what they think they're getting. So that's going to take a bit of time. I think clearly there is a balance, as I think Rosalind said, that, you know, about risk and benefit, and what essentially I think the UK and other regulators have just said, look, you know, the benefits are so large in where there is this pandemic going on, and you know, people are dying every day, that outweighs the uncertainty that we have. But we are in a very different situation in Australia, and I think we can afford to wait. And so the federal government has indicated that you know, approval will probably be in the order of February or March, and then the vaccine program will be rolled out shortly thereafter. And that will also give us some data from the countries that have rolled it out, to see if there are any safety signals that we need to look out for, whether there are any other issues that might be relevant.
But obviously, we're going to have to kind of follow this vaccine closely for safety and efficacy. And Jody, you know, do we have what needs to be in place to actually monitor the safety and effectiveness of the COVID-19 vaccines in Australia? And what do we need to get in place for appropriate pharmacovigilance for these new drugs?
We do have the Australian Immunisation Register, which is being souped up to be able to capture these vaccines, and obviously that's been a system that's been being built up over recent years to expand on what was the Australian Childhood Immunisation Register, so that we can capture vaccines across the lifespan. There are obviously also vaccine safety monitoring mechanisms in place, and again, I think part of the preparation for this is working out exactly how those connect and what the enhanced systems are. And Ellen may be able to speak to that a little bit in more detail than I am, because I've been less involved on that side. But clearly we will need to be monitoring safety in a very proactive manner. And this is where I say we're going to need to remain adaptable to emerging signals about the vaccine, being sure that we're interpreting them appropriately, that they receive thorough review, that we understand their meaning, and are then able to, you know, make any necessary changes to our program or our schedule as indicated based on that best emerging evidence. So it's, you know, going to be learning as we go, because we simply can't know everything before we start. And it's very important that we have evidence-based guidelines and we review evidence, but when there's something new, we won't always have that full body of evidence, and we do need to go ahead with our best understanding at the time and take the public with us.
So we won't know everything when we start, and then that's definitely true. Magda, you know, the H1N1 vaccine was similar, and what did we learn from that? What did we learn from the tragedies that happened with the H1N1 vaccine?
That's a really good question. We learned that we need to take this window of opportunity that we have to learn from the UK and not rush into it. That's I think that we've actually been given a really good opportunity here to watch what's happening overseas, and we're in a situation where we have very few cases nationally. I think less than 60 nationally, and I think that we are poised to be able to use the information from what's going on in the UK. And I think in Brazil, they're the next country that are going to roll it out in January, to learn from any potential adverse events. And really, as we've all acknowledged, this is a sort of a strategy that's being evolved as we go. So it changes, it's live, just as the COVID task force is developing guidelines day by day, changing them. We will need to adapt to that. And I think that in general practice, we have this relationship with our patients based on trust. And it's really hard to, as a GP who has this position and this role and relationship with your patient, to advocate for something when you don't feel in your gut that it's the right thing to be doing because you don't have enough information as yet. So I think that what we've learned is patience is a virtue, and that we've got that on our side because we're in a really good position.
I think there's considerable uncertainty and more than usual. And Sonia, how do you think this is going to affect vaccine hesitancy, and what can we do now to start kind of preparing the groundwork, preparing it so that people are accepting of the vaccine when we have it to deliver?
Yeah, that's going to be a real challenge, I think. And I think the most important thing is to be honest. As Jody said, it's hard to know absolutely everything, and so it's no point sort of fumbling through, making things up. You just have to be honest of the things that you know and the things that you don't know. And I think, as Roz has pointed out, normally whenever you talk to families or talk to anyone about a vaccination, you do this, risk versus benefit discussion. And what you can do, particularly when I talk to families about meningococcal disease, for example, is, you can show them, videos of children with, debilitating sequelae as a result of meningococcal disease. But, we haven't really been able to see, what happens with COVID-19, other than, the sort of mass grave videos we saw in New York, etc. But you haven't really seen patients in ICU, or, like you would a baby coughing with whooping cough, to sort of have that risk versus benefit discussion. But yeah, I mean, it's just important that we try and answer people's questions, that, as Magda has said, that we as the providers, standing there with needle in hand, have enough information that we can have those conversations with people and really know, what is the vaccine we're giving, what is the efficacious outcome of the vaccination, what are the side effects, and that we also do really have these robust systems in place, to monitor for those side effects afterwards. We've got SafeVic, and we've certainly learnt a lot since the H1N1 in terms of, Vax Tracker apps and things, people automatically getting a message after they've received the vaccine saying, have you had a, reaction? So I think we're certainly well placed in terms of that to communicate, the safety and confidence in the vaccines.
So Roz, there are going to be groups of people that don't want the vaccine or are hesitant. There are also groups of people that won't be able to have the vaccine. We saw now they're not recommending that people who have, severe allergic reactions, that they don't receive the Pfizer vaccine. I think likely a vaccination is going to be, a necessary step to access some social activities. And so doesn't it become kind of de facto mandatory if, you can't get on a Qantas flight unless you're vaccinated, so you can't travel, if you can't be a healthcare worker unless you're vaccinated. So how are we going to manage those things? So what's, should we have passports? What are the ethics of that?
Very big questions, Nancy.
Just a little problem, Roz, just a little problem.
So I think there's sort of two different types of ethical questions there. One is about, should vaccination be a hurdle to certain activities or sort of social goods? And then the second question is, who should make those decisions? So should it be up to a individual airline or an individual cafe or an individual business to say that a vaccine is required in order to access our service? Or are they decisions that are more appropriately sitting with government? So the who should decide question is one, but then I think this issue of a vaccine as a hurdle to certain social activities, I wouldn't say that makes vaccination mandatory, but it certainly changes the choice architecture around vaccination. And I think it's really interesting that in this discussion we've got kind of both ends of the spectrum. We've got this kind of priority question about who's going to get it first, and then at the other end the issue about people not wanting vaccine at all. And so I think it really highlights the extent to which vaccination happens in a social context, that different people are going to understand it and interpret it and see it in different ways. So understanding that social context around vaccination is going to be really important alongside the kind of medical and epidemiological information.
Sonia?
Yeah, it's interesting because really we've seen it a little bit with the no jab, no pay and play legislation, where it's not mandatory to get your child vaccinated. However, you won't be entitled to family assistance payments and you can't enrol your child in kindergarten if they're not up to date with their vaccinations. And I guess what it does is there'll be always vaccine refusers, and they'll just say, oh, well, that's fine, I'm not going to send my child to kindergarten, then I'll just wait until school and then enrol them. So there'll be a proportion of vaccine refusers. But there is also this vaccine hesitant group who, what that legislation I think does is actually encourage them to have a conversation. So rather than, you know, stick my boots in the ground, it's making me have this conversation with a immunisation, you know, expert or with my GP that I previously might not have had. And so I think, you know, this hurdle requirement, as Ross said, I think it may just encourage people to have a conversation if they, you know, there'll be the refusers that say, that's great, I just won't go on Qantas, so I'll travel with somebody else. But I think it does just encourage people to have a conversation about the vaccine.
I think you have to be, you know, practitioners have to be open to those conversations, right? Or else, you know, it's definitely going to affect uptake. So now we're going to take some questions from the audience, and we have Abby Minter and Zainab Qureshi who are going to help with that. Abby is the Deputy Director of the Global Health Alliance and is also the Program Policy and Events Officer for Pacific Friends of Global Health. She has a Master's in Public Health and a Bachelor of International Studies, and previously was the National Manager of Ethiopiaid, and has been really helped us organize this, and really many thanks to you, Abby, for making this really seamless. And then Zainab Qureshi, who is a Master of Public Health student at the Melbourne School of Population and Global Health, who has really very effectively led that organization, creating and led that organization this year. She's passionate about women's health and primary health care, and as I said, she's the current president of the Student Society. So let's hear the questions from the audience.
I'll start. Sonia and Magdalena, you've both mentioned education of the health workforce. And do you know what's being done at the national and state level to ensure that we're going to have enough staff, so nurses, GPs and pharmacists, trained in immunisation to deliver the vaccine at a sufficient scale?
Right, well, do you mind if I start with that, Sonia, then you can finish up? Yeah, because I can talk about what we do have. I mean, GPs at the moment form part of the core immunisation, national immunisation strategy. So general practice is the home of this, and we've been experts in delivering vaccination programs and also adapting them to you know, change, for instance, you know, with the H1N1 and swine vaccine and all the rest. So we adapt, and we have trained and educated staff. The main thing here is going to be around management and logistics around the vaccine type. So it's not so much about administering, whether it's a multi-dose vial or whether it's a single, you know, a syringe per person. It's really about how you time the logistics around the handling of the vaccine. And the other thing is that we're probably not going to be working with only one vaccine type, that we're going to be working with a variety of vaccines, and we're going to have different education around the needs and the vaccine specifics. So it's not so much, I think that the workforce can be mobilised because we're doing it in phases, and we're doing it according to priority groups, which of course Rosalind just touched on. And that's out of necessity because of global supply and demand issues. Yeah. And the rest, I think that we can mobilise our existing staff. I'm sure Sonia will probably, you know, add to that, because immunisation nurses are excellent and also capable of administering this outside of centralised areas.
Yeah, thanks, Magda. So from a nursing perspective, in Victoria, 45% of immunisations are actually provided through local council, through local government. That's predominantly childhood scheduled vaccines. And so what the Nursing Midwifery Board of Australia have done is actually put out an email to all nurses registered with APRA asking for their nurse immuniser qualifications and who is actually an accredited nurse immuniser. And that's to get a sense of what are the numbers that we currently have, you know, ready to sort of hit the ground running, if you like. The other thing is to be an accredited nurse immuniser, you need to do an approved course of study. and they can be quite expensive, and they go for a couple of months at a time to obviously learn the whole immunisation program. And so there are conversations being had at the moment in terms of how can we do an abridged program of study specifically for COVID vaccine that would enable people to be accredited a lot quicker and ready to go, purely just to provide that. And we've seen that this year with Monash actually developing a program for paramedics to deliver flu vaccine in their workplace. So it's certainly something that's being looked at the moment to try and expedite the nurse immuniser workforce ready to go.
All right, thank you. I've got a question here for Professor Chang. So the community health sector in Victoria has extensive reach, trusted relationships with clients and patients, high quality community language capacity, and established relationships with community and community leaders. Will the community health sector be enlisted as part of the workforce to roll out the vaccine?
Look, I think the principle in public health is that healthcare and public health and communication is best delivered by people who are closest to the communities, and I think that goes to Magdalena's point about general practitioners being a trusted source of information. But certainly, for example, in COVID public health, this move in Victoria from sort of central public health into these local public health units has been a big change, where public health responses are delivered by often, by health services that have pre-existing links to communities and sometimes the people that are being involved. And that goes the same with, for example, with co-health or some of the community service organisations that have been involved in public health. I think it will be the same with vaccination. But I guess a question that I was actually going to put back to Magdalena and Sonia was, there, particularly with the logistical issues, there is going to be a tension between getting this as far out and as close to the communities as possible, and through general practitioners and so on, but also just because of logistics, that there is going to need to be some centralisation, possibly around hospitals, which will have the infrastructure. So as an example, the Pfizer vaccine comes in these pizza boxes with 1,000 doses, and you basically have 5 days to get use all of those doses. So it probably, for example, isn't going to be possible to have a solo general practitioner. They're not going to be giving 1,000 doses of vaccine in 5 days. So how do we balance that that need to sort of centralise it for logistics, but make it more diffuse to optimise coverage and communication and delivery?
Well, I think that what you've pointed out is really interesting, because it's what we're thinking about also, and how we time it and how we actually, the logistics of keeping the vaccine at the temperatures that are required, and timing vaccine delivery. So we have our flu clinic sessions where we're delivering flu at a particular segment of the day, and we have an allocated GP who does that with a nurse, or even a nurse practitioner who's doing it at the clinic at the same time. So there is capacity when you have a process that's strategic and streamlined, and that you coordinate your patients. One of the big issues is going to be accessing the people who are in the priority groups. And that is, so one thing is saying that we've got these systems, but how do we access the patients, and how do we draw them in, and how do we get them in, and how do we give them the education, the information, answer their questions, and provide the consent in that particular process. So for instance, with flu vaccine, we can have our flu clinics and people line up for them. But with the COVID vaccine, that's going to be very different. So it's not just the logistics of the vaccine, which I think that we can handle. We've got thermoses, we've got ESCI. I think what you've talked also about, Alan, is that the ESCI system that they had for the Ebola virus did work, and that was in Central Africa. So we have the willingness is what GPs have revealed, that they have the adaptability and the willingness to mobilise and provide what's needed for the community, provided we're given also the facilities and the support to do that. The other thing here is going to be around the time of delivery for the second one. So recall systems and getting patients back for the second dose. Getting the information out to people that one vaccine alone doesn't immunise you, or doesn't vaccinate you or protect you. And that there's this window from the first to the second and then until full immunity that might be even up to 6 weeks. So they're really interesting messages that we need to be developing for people to understand that having one jab doesn't protect you. Having 2 jabs, well, you need to have the second, but you also need to wait another 3 weeks after that before you are protected adequately.
So we're ready to go, actually, Alan. So, So the immunisation service at the Children's Hospital is predominantly vaccinates children, of course, and that's not going to be the target group for this vaccination. So one thing that we did this year was actually a proof of concept of a drive-through vaccination model, and that's where patients actually all booked in beforehand. We had the handheld devices to check people in as they came. And what we expect to do, our service, is actually extend that to the Parkville precinct. So actually, because we know that the Royal Women's, has pregnant women, and we've got the Peter MacCallum Institute, we've got the Royal Melbourne Hospital, they don't have an immunisation centre, but we would definitely be looked to, supporting those patient groups to come through, a drive-through vaccination model at the RCH. We've got the infrastructure there in terms of freezers, etc. So yeah, we're all ready to go.
So Abby and Zainab, I think we have time for one more rapid question. So what's a burning one?
I think for Jody, actually, given the differing COVID experience and epidemiology in different parts of the country and therefore differing risk perception, do you envisage that there'll be challenges in generating vaccine demand and overcoming hesitancy in different parts of the country?
Yes, I mean, I guess Victorians have had a very different experience of COVID from the rest of Australia, but still what we've seen is nothing compared to the global north, So I think it will be interesting to see how much of this we hold in our minds, and what we have is a fear of constraint more than a fear of disease. Although clearly that's with full respect to people who have experienced loss or who have experienced the disease, who are still among us. But relatively speaking, those numbers are few. It's been a challenge all through the pandemic, managing the country in different states, and that was something we actually anticipated after H1N1, that could be an issue. But yes, I think trying to keep a national cohesion, keeping a national strategy within that, again, having the adaptability to say, if there is an outbreak in one state or territory, we may need to reallocate our priority to that state and territory. And so having that national conversation in advance and having a clear understanding and a dialogue with the public about how we might manage things as they unfold. We all hope we'll get our, some vaccines in from March, but we're, looking at what's happened in the Northern Hemisphere as we're coming into winter. We may well see an increase in transmission risk, as other countries seem to have done. So all of that will be a really important ongoing dialogue.
Well, thank you very much, everyone. I think we're going to have to wrap this up because we do turn into a pumpkin at 6:30. I want to thank all our panelists, as I'm sure everyone, all the audience does as well. So Professor Alan Chang, Ms. Sonia Ellis, Dr. Ross McDowell, Professor Jody McVernon, and Dr. Magda Santos. Thank you so much for your time and for your extremely edifying comments. I know we have more questions than answers, but I am so glad that we're in the position that we're having all these questions, because it's just amazing to not even be in the new year and already be thinking about how we actually deliver the vaccine to every Australian who is interested in taking the vaccine. So thank you very much. Thanks to everybody who participated in this webinar. If you have suggestions for future webinars, please contact the Student Society. I'd like to greatly thank the Student Society as well as the Global Health Alliance for their contribution and help in organizing this webinar. And remember, this will be broadcast on YouTube, and we will send the link to the registrants. So please feel free to share that or to watch again. So thank you very much, everyone, to the participants and to everyone who helped organize this for a great conversation. Bye for now.